Hey guys, in this video I'm going to talk about the vitamins. So vitamins are divided into mainly two types, water soluble and fat soluble. Water soluble are vitamin B and C, and fat soluble is A, D, E and K. So total we have A, B, C, D, E and K. This six type of vitamins, and this B and C is water soluble, while fat soluble is A, D, E and K. So water soluble vitamins is going to be excreted from the kidney by urine, so there is no chances of toxicity, while fat soluble vitamins are mainly stored in the adipose tissue and in liver, and there is chance of toxicity. And this vitamin B and C mostly acts as a coenzymes. Now first, let's see the vitamin A. So here fat soluble is A, D, E and K. A, D, E and K. Absorption depends on the bile emulsification, pancreatic secretion and intact ileum. So for that absorption we know that fat has to be absorbed with it. So bile emulsification, pancreatic secretion and intact ileum should be required. Toxicity more common than for water soluble vitamins because fat soluble vitamins accumulate in the fat. And malabsorption syndrome with steatorrhea like cystic fibrosis and celiac disease or mineral oil intake can cause fat soluble vitamin deficiencies. Now the water soluble, so this whole B, so B1, B2, B3, B5, B6, B7, B9, so thiamine, riboflavin, niacin, pantothenic acid, pyridoxine, biotin, folate and cobalamine plus vitamin C, that is ascorbic acid, wash out easily from the body except B12 and B9. B12 are stored in the liver for 3 to 4 years, while B9 stored in the liver for 3 to 4 months. B complex deficiencies often result in dermatitis, glossitis and diarrhea. Can be coenzymes or precursors of coenzymes. So this was broad classification how fat soluble and water soluble vitamins have totally different pathway, because fat soluble are going to be absorbed with the fat plus stored in the fat, and that's why they have more toxicity, and water soluble have less toxicity due to their urine excretion. But this B12 and B9, B12 is stored in liver for 3 to 4 years, while B9 stored in liver for 3 to 4 months. So now vitamin A. Vitamin A includes retinol and retinoic acid. So alcohol, aldehyde and carboxylic acid form, and the function is mainly antioxidant, constituents of visual pigments, essential for normal differentiation of epithelial cells into specialized tissue, pancreatic cell, mucus secreting cells, prevents squamous metaplasia. So mainly for the vitamin A we know that it is mainly important for the eye and epithelium. So essential for normal differentiation of epithelial cells into specialized tissue, mucus secreting and pancreatic, and prevents squamous metaplasia and constitution of visual pigments, plus also antioxidant. So antioxidant vitamins are actually vitamin A, C, and E. Now, retinol is vitamin A, so think retin A used topically for wrinkles and acne found in liver and leafy vegetables. Supplementation in vitamin A deficient measles patient may improve outcome. So mainly used for all the skin disorders like wrinkle, acne. For measles, vitamin A deficient measles supplementation will improve. Oral isotretinoid used to treat severe cystic acne. All trans retinoic acid to treat acute promyelocytic leukemia. This use is very important. Now about the deficiency, so first eye will be affected, so that's why the night blindness, also known as nyctalopia, dry scaly skin, that is xerosis cutis, dry eyes, xerophthalmia, conjunctival squamous metaplasia, bitot spot, corneal degeneration will be there, keratomalacia. So night blindness, dry scaly skin, xerosis cutis, dry eyes. So this is the classification. Uh, N for night blindness, S for corneal scar, F for xerophthalmic fundus. So first for A we are going from superficial to deep. So conjunctival xerosis, bitot spot, corneal xerosis, and then corneal ulcer. So this was about the eye night blindness, nyctalopia, dry eye, xerophthalmia, conjunctival squamous metaplasia, that is Bitot spot. There will be keratin debris, foamy appearance on the conjunctiva, then corneal degeneration, that is keratomalacia, and immunosuppression. This corneal ulcer is same as keratomalacia. Now the toxicity. So toxicity will cause nausea, vomiting, acute toxicity, increase in ICP, so vertigo and blood vision. Chronic toxicity will cause alopecia, dry skin, hepatic toxicity and enlargement, then all the derangement of lipids, so hyperlipidemia, and idiopathic intracranial hypertension, pseudotumor cerebri, and arthralgias. That's why if the patient is on any vitamin A analogs, we have to check the LFT frequently, their lipid levels frequently, to check if there is any hepatic toxicity and lipid derangement or not. And the most common side effect is this dry skin. Teratogenic interferes with homobox gene, cleft palate, cardiac abnormalities. So this is teratogenic. Why? So before initiating this drug, we have to check for the urine pregnancy test because it is highly teratogenic. Therefore, a negative pregnancy test and 2 forms of contraceptives are required before isotretinoid is prescribed. So this was about the toxicity and deficiency. So in vitamin A, you have to remember skin and eye, these two things, that if there is deficiency, then there will be this whole eye around finding plus dry skin will be there, xerosis cutis. But if there is toxicity, then dry skin, alopecia plus ICP will increase, so blood vision and vertigo will be there. Plus extra you have to remember hepatic toxicity, lipid derangement, and this teratogenic features. Plus there is also fryoderma, that is related with vitamin A deficiency. Now about the vitamin B1. So B1 is a thiamine, and thiamine, we have remembered this B apt mnemonic, because thiamine pyrophosphate is cofactor for several dehydrogenase enzyme reactions. So B apt, first is branch chain ketoacid dehydrogenase, alpha ketoglutarate dehydrogenase, that is in TCA cycle, pyruvate dehydrogenase, that links between glycolysis and TCA cycle, plus transketolase, that is in HMP shunt pathway, mainly in the RBCs. We check the level of transketolase from the RBC. Now the deficiency part. So deficiency will cause impaired glucose breakdown. That's why ATP depletion worsened by glucose infusion. Highly aerobic tissues like brain and heart are affected first. In patient with chronic alcohol overuse or malnutrition, give thiamine before dextrose to decrease the precipitating vernix encephalopathy. And diagnosis is made by increase in RBC transketolase activity following vitamin B1 administration. So this is a diagnostic test. Increase RBC ketolase activity. So here is the same thing, that B apt oxidative decarboxylation reaction. That's why it is known as dehydrogenase enzyme. So there is, in this reaction, two things is happening. First is dehydrogenation, means oxidation. In the second one is decarboxylation, but by default we are referring them as dehydrogenase enzyme only. So this for enzyme B pneumonic we have to remember. Then assay, we are RBC transketolase assay are doing for the diagnosis, and there will be ATP depletion plus lactic acidosis and transketolase ATP shunt pathway. Yes, that we have learned. Now, the deficiency will cause all of this disorder. So B1, dry beriberi and wet beriberi plus this Korsakoff syndromes, Wernicke encephalopathy and Wernicke-Korsakoff syndrome. So these disorders we have to learn. So dry beriberi and wet beriberi. Dry one, there is no heart involvement, so only neuropathy will be there. So polyneuropathy plus symmetric muscle wasting. While in wet beriberi there will be high output cardiac failure due to systemic vasodilatation. Now in Wernicke case there will be Goa pneumonic. So what is this Goa pneumonic? That is global confusion, ophthalmoplegia and ataxia. And areas affected are important, that is dorsomedial thalamus, mammillary bodies, aqueduct of sylvius and periaqueductal gray area. So dorsomedial thalamus, mammillary bodies, aqueduct of sylvius and periaqueductal gray area. This area are mainly affected. You can remember that the W. So this W, you can make it M, and remember that this is dorsomedial area plus mammillary body. This is thalamus. Now the Korsakoff, so there will be amnesia plus confabulation. Due to amnesia, patient will make up their own stories to fill the memory gap, and patient this is doing unconsciously. They don't know they are doing this. So damage to what will happen in this Korsakoff syndrome? It is amnestic disorder due to chronic alcohol overuse. Patient with presents with confabulation, personality change and memory loss, that will be permanent. Now, so we have seen this Wernicke's encephalopathy, acute reversible. So Wernicke's encephalopathy is reversible condition, while this memory loss is permanent. So acute reversible life-threatening neurologic condition, symptom confusion, global confusion, ophthalmoplegia or nystagmus and ataxia. Now, amnestic disorder due to chronic alcohol overuse present with confabulation, personality change and memory loss. Now, this Wernicke-Korsakoff syndrome, damage to medial dorsal nucleus of thalamus and mammillary bodies. Presentation is combination of Wernicke's encephalopathy and Korsakoff syndrome. So, in this there will be both Wernicke's encephalopathy plus Korsakoff syndrome. And we have learned about this dry beriberi and wet beriberi. Dry is only neuropathy, while wet beriberi there is high output cardiac failure due to systemic vasodilatation. Now vitamin B2 also known as riboflavin, and this is this component of flavin, FAD and FMN used as a cofactor in redox reactions. Example is succinate dehydrogenase reaction in TCA cycle. Now the deficiency will cause chelosis, means inflammation of lips, scaling and fissure at the corner of the mouth, and magenta tongue. So mainly the mouth area plus corneal vascularization. And here we check the RBC glutathione reductase level. Cheilitis, stomatitis and glossitis, magenta colored tongue. Cheilitis, stomatitis and glossitis, so magenta colored tongue. In vitamin B2, you can remember riboflavin from red, that it is all causing this thing red around mouth and around the eye, in eye. So in eye it will cause corneal vascularization, so all the little arteries will be visible in the cornea, and in mouth it is causing cheilitis. This angle of mouth is getting affected, so corners of mouth there will be fissures and inflammation plus stomatitis and magenta colored tongue. So this was about the deficiency and function. They both are not relatable that much, but we have to remember component of flavins, FAD and FMN uses a cofactor in redox reaction, that is succinate dehydrogenase reaction in the TCA cycle. Now vitamin B3, also called as niacin and nicotinic acid. Now this will form NAD and NADP used in redox reaction as a cofactor of dehydrogenases derived from tryptophan. Now this niacin will be derived from the tryptophan. So niacin, serotonin and melatonin, these three are main derivatives of the tryptophan. Synthesis requires vitamin B2 and B6 used to treat dyslipidemia. So this thing we have to remember, that it B2 and B6 are used for the synthesis of B3. So you can remember that 6 divided by 2 is 3, that's why. And also it will cause glossitis, the deficiency, and from deficiency so diarrhea, dementia, dermatitis and after death. And in dementia you have to remember that it will cause broad collar like rash. This is castle necklace, as you can see here. It will occur in the sun exposed area, so hyperpigmentation. So this 4D you have to remember in the deficiency plus, and this is known as the pellagra. Now about something tryptophan metabolism, because tryptophan metabolism, what will happen from tryptophan, there will be serotonin formation also and niacin formation also. So if serotonin formation will increase, then what will happen, the synthesis of niacin will decrease, and that will happen in malignant carcinoid syndrome. So one thing you have to remember about the deficiency is this carcinoid. Carcinoid. Second thing you have to remember is this Hartnup disease. What will happen in the Hartnup disease? It is an autosomal recessive deficiency of neutral amino acids like tryptophan transporters in the proximal renal tubular cell and on enterocytes. So neutral amino acid urea will be there, and from decreased absorption from the gut. So tryptophan for the conversion of niacin will be decreased and pellagra-like symptoms will be there. So second is Hartnup disease. Third is, if the people are on a diet of any maize, corn, it contains less tryptophan. I think that's why it will also develop this tryptophan deficiency symptoms. Plus also people on isoniazid. Isoniazid will also cause defective vitamin B6, and we have learned this B6 is involved in synthesis of B3. So deficiency will happen in isoniazid plus OCPs plus malignant carcinoid, Hartnup, maize diet and jowar diet. So diet related to this is maize, niacin deficiency and jowar. Because there is leucine malabsorption will be seen here. I don't know how leucine malabsorption will cause. I have to search about this. How maize and jowar can cause niacin deficiency. Maize and jowar sorghum contains high level of leucine that inhibits the conversion of tryptophan to leucine, conversion of quinolinic acid to nicotinic acid, and can cause niacin deficiency. Okay, so this leucine will inhibit the conversion of tryptophan to niacin. Excessive leucine alters the normal metabolism of tryptophan and thereby contributes to low level of niacin. Corn or maize as a main food source can lead to pellagra, as these foods are low in both absorbable niacin and tryptophan. Chronic alcoholism, the absorption of several nutrients, particularly water-soluble vitamins including B family, decrease with excessive alcohol intake. So here what will happen, that maize deficiency will be there, plus in jowar what will happen, the conversion of tryptophan to niacin won't happen. So maize, jowar means sorghum diet, also people on the alcohol, then Hartnup disease, absorption won't happen, then carcinoid syndrome, niacin won't convert into tryptophan won't convert into niacin, it will convert into serotonin, plus isoniazid and OCPs will cause vitamin B6 deficiency. So these all are syndrome related to vitamin B6 that we have to remember. It is oftenly asked in the exams, and the deficiency part plus its toxicity is also very important. So let's see the facial flushing produced by prostaglandin, not histamine. This we have to remember, that it is induced by prostaglandin and not histamine, can avoided by taking aspirin before niacin, pruritus, hyperglycemia and hyperuricemia. and therapeutic use is dyslipidemia, so increase HDL level. So remember that this will cause hyperglycemia but decrease, I mean it is used in treatment of dyslipidemia because it is going to increase HDL level. Also hyperuricemia and this pruritus plus facial flushing. So these two you can remember from prostaglandin only. Now this podagra is vitamin B3 overdose and pellagra is where vitamin D3 level will fell. So for vitamin B3 you have to remember about this 4D plus all the deficiency part, that what are the foods that will cause the deficiency, what are the syndromes related to this will cause the deficiency, plus B6 deficiency can also cause the deficiency. All of this you have to remember. Now vitamin B5 is pantothenic acid. So pento, you can remember pent means 5. Now function, components of coenzyme A. So it is act as coenzyme A, that we CoA, right, is a cofactor for acyl transferase and fatty acid synthesis. It will also cause dermatitis, alopecia, then adrenal insufficiency may lead to burning sensation of feet. This is very important, burning sensation of feet. So remember that pants have this feet down there. So burning feet syndrome, distal paresthesia and dysesthesia. This we have to remember. Burning feet syndrome plus adrenal insufficiency. This two thing is important. Dermatitis, alopecia, enteritis you can remember, but this two thing is very important. Now vitamin B6, that is pyridoxine. This vitamin is also very important, just like niacin. So converted to pyridoxal phosphate, that is PLP, a cofactor used in the transamination. So this enzyme is very important in the transamination reaction, like alanine transferase and aspartate transferase, mainly in the liver, and we also use this as a liver function test, ALP and SG, that is your SGPT and SGOT. Now also important thing is it is useful in decarboxylation reaction, glycogen phosphorylase, synthesis of glutathione, cystathione, heme, then niacin, histamine, neurotransmitters including serotonin, epinephrine, norepinephrine. It will come everywhere, dopamine, GABA. If you search this decarboxylation reaction related to vitamin B6, then you can also get many answers of this, like GABA formation, dopamine formation. So decarboxylation reaction, as I am writing here, so the the synthesis part. What's the function? First is the transamination reaction. Second one is this decarboxylation reaction, glycogen phosphorylase. So this GABA, this dopamine and epinephrine, norepinephrine, GABA, dopamine, epinephrine, norepinephrine. Serotonin synthesis. Plus histamine. So for this heme synthesis, there is sideroblastic anemia and anemia and vitamin deficiency. So B6 will cause sideroblastic, B12 and folate will cause macrocytic, and vitamin B cause hemolytic anemia. Epinephrine, norepinephrine, dopamine plus histamine, GABA, niacin, synthesis of glutathione and cystathione. All of this is very important. Now this tryptophan, there is kynurenine 9 pathway is there. So and in this there is xanthinic acid will be formed. That's why in tryptophan load we will give this tryptophan load and xanthinic acid will decrease in urine. This is useful for the assay of vitamin B6. Its deficiency will cause conversion, hyperirritability, peripheral neuropathy, deficiency inducible by isoniazid and oral contraceptives, sideroblastic anemia due to impaired hemoglobin synthesis, and iron excess. So this was about the deficiency part. Now vitamin B7. Vitamin B7 is known as biotin and it is cofactor for carboxylation reaction which are work carbon atom group. So pyruvate carboxylase, that is useful in gluconeogenesis from pyruvate to oxaloacetate, acetyl CoA carboxylase, fatty acid synthesis, acetyl CoA to malonyl CoA, then propionyl CoA carboxylase, fatty acid oxidation and branched chain amino acid breakdown. So propionyl CoA to methyl malonyl CoA. Deficiency is relatively rare, but when you ingest lots of raw egg white, there is avidin which cause biotin deficiency, or long-term antibiotic use can also cause this. Now the deficiency will cause dermatitis, enterititis and alopecia. So B7 and B5 there was same only, dermatitis, enterititis, alopecia, but in B5 we have remember burning feet syndrome plus also this adrenal insufficiency, and here there was not there. Now vitamin B9 known as folate. Vitamin B9 and B12 is very simple to remember. So this folate will be converted to tetrahydrofolic acid, THF, a coenzyme for one carbon transfer methylation reaction, and it is important for synthesis of nitrogenous base in DNA and RNA. Found in green leafy vegetable, also produced by gut microbiota. Folate absorbed in jejunum. Small reserve pool stored primarily in the liver. Now the deficiency will lead to macrocytic megaloblastic anemia, hypersegmented polymorphic nuclear cell, then glossitis, no neurological symptoms is opposed to vitamin B12. So mainly macrocytic megaloblastic anemia will be there and hypersegmented polymorphonuclear cell will be there. No neurological symptom as opposed to vitamin B12 deficiency. Homocysteine level normal, methyl malonic acid level, and so increased homocysteine vacancy seen in chronic alcohol overuse and pregnancy. Deficiency can be caused by several drugs like phenytoin, trimethoprim and methotrexate. Supplement, that's why methotrexate, also trimethoprim and phenytoin. Supplemental folic acid at least 1 month prior to conception and during pregnancy to decrease risk of neural tube defect. Give vitamin B9 for the 9 month of pregnancy and 1 month prior to conception. This we have to remember also. This deficiency will cause neural tube defect. Now the vitamin B12, also known as cobalamin, cofactor for methionine synthesis, transfer of methyl group as methyl cobalamine and methyl malonyl CoA mutase, important for DNA synthesis. Same. So and here also macrocytic megaloblastic anemia will be there, segmented polymorphonucleotrophils, paresthesia, but here will be this neural part, that is paresthesia and subacute combined degeneration of dorsal column, lateral corticospinal tract and spinocerebral. This is very important question, that there will be dorsal column that is getting affected, lateral corticospinal tract and spinocerebellar tract. So these three things we have to remember, that is lateral corticospinal tract. Due to abnormal myelin associated with increased serum homocysteine and methyl malonic acid level along with secondary folic acid deficiency, prolonged deficiency will cause irreversible nerve damage. So very large reserve pool will be there of 7 years stored primary in the liver. Deficiency will caused by malabsorption. In this diphyllobothrium latum is important. Achlorhydria, intrinsic factor will won't be there. Bacterial overgrowth, alcohol overuse, lack of intrinsic factor, pernicious anemia, gastric bypass surgery, absence of terminal ileum, surgical resection for Crohn's disease, certain drugs like metformin, insufficient intake, vegan and B9 supplementation can make these hematological symptoms of B12 deficiency suppress, but neurological symptom will get aggravated. This is very important about this synthesis part, how vitamin B12 and B9 is related. Vitamin C, D and E and K, this four I will cover in the next video.